Hi, good evening, everyone, distinguished audience. My name is Evandro Vasconcelos. I'm a head and neck surgeon in Curitiba, Brazil, and I'm a proud member of LATS and of the AAES, the American Association of Endocrine Surgeons. It's my privilege to host this first webinar and co-moderate this first LATS and AAES joint webinar with Dr. Ana Vogt from Argentina. Dr. Ana Vogt is the chair of the head and neck surgery department in the Hospital Austral in Buenos Aires. Is also a member of the LATS surgical committee. We are going to be together moderating this webinar. It's a tremendous night and a great honor. We have a very, very distinguished program, and I'd like to salute and congratulate the LATS and the AES leadership for supporting this important educational initiative focused on the thyroid cancer. So we are going to have two talks, and after the talks, we are going to have a case discussions, and we are going to open space for questions of the audience. The audience can send questions for the speakers and for the cases by the chat. The question is going to be posed at the end. Our first presenter is Dr. Julian Sosa. Dr. Julian Sosa is going to present us the lecture, Who Needs a Total Thyroidectomy? I am sure that everyone knows her. Dr. Sosa is chair of the Department of Surgery at the University of California at San Francisco. She's also professor of the Department of Medicine and affiliated faculty of the Philip Lee Institute for Health Policy Studies. And she is currently the leader of the task force that is writing the new thyroid cancer for the ATA guidelines. Dr. Sosa, the stage is yours. Thank you for having you. Hi, Julian.
Okay, can everyone see that? That's always the hardest part. Can I share my screen? Okay, so Evandro, thank you so much for that very warm welcome. And thank you to the AAES and to LATS for this really privilege to be able to join this webinar, participate with such illustrious and esteemed international colleagues. And thank you to everyone out there on the webinar. I know in many parts of the world it is evening and this is stealing time away from family and friends, but just really that reflects our collective commitment to advancing the field of thyroidology on behalf of our patients. So I just would like to start with grace and gratitude. So I have been asked to speak to you today about who needs a total thyroidectomy. And I guess the short answer, we can cut to the chase, is maybe fewer and fewer people. But I think it is actually a very nuanced question. And I hope to be able to help all of you think through in a very contemporary way what the evidence supports in the way of guidelines. And on the right, you can see a seismograph. I always try to throw in a seismograph because I'm in San Francisco, California, and we have a lot of tremblers out here. But I think this represents change. And I do think change is impending with regard to how we think about surgery for differentiated thyroid cancer. These are my disclosures. They pertain only to medullary thyroid cancer, and my discussion today will be restricted to differentiated thyroid cancer. So when I'm not doing thyroid surgery or thinking about the thyroid gland, I really love to read. And this is one of my favorite authors, Adam Grant. He's an organizational psychologist at the Wharton School in Philadelphia. And this is one of my favorite books that he's written. It's called Think Again. It was written during the pandemic. And in this book, Adam Grant really helps us to think about change and to think about why all of us have so much aversion to change. And this quote from the book sort of is the underpinning to that. Once we hear the story and we accept it as true, we really rarely bother to question it. Why? Because to change, we have to unlearn what we are doing and then relearn something new. And that's super labor intensive and it's very hard. And I think when it comes to thyroid surgery and how much thyroid surgery to do, if any, um, there is a process of change that is foundational. If I were to look at a really high level about where we are today with regard to how much surgery, if any, we should do, in many ways, the contemporary perspective reflects where we were 20 or 30 years ago. So what goes around comes around. And I'm going to be focusing today on evidence-based guidelines, and I'm actually going to be giving you a preview of the upcoming American Thyroid Association 2025 guidelines. But before we talk about those and the advice they give around extensive surgery, I wanted to just share these data, which show what impact, if any, guidelines have on how much treatment we give and how much surgery we do. This is a study we did using US data reflecting on 18 years and the time trends with regard to the first course of treatment. We reviewed the experiences of more than 105,000 patients. And at a very high level, I want to show you on the left, these are patients with low-risk tumors, 0 to 4 centimeters in size. These are patients on the right with high-risk, intermediate and high-risk tumors, greater than 4 centimeters in size. And the first thing that you see is that there was an acute decline in really the use of radioactive iodine that started in 2009 and that continued. And this line is total thyroidectomy with radioactive iodine. So combinatorial treatment has declined, sort of corresponding with the publication of ATA guidelines. At the same time, there has been a slow rise in total thyroidectomy. So I dissect that out to really want you to reflect on the fact it's really radioactive iodine that has primarily fallen away. And then most recently, in around 2015, when the last set of guidelines were published, this rise of thyroid lobectomy. Okay, so clear impact or association of guidelines with practice patterns. Interesting, when you look at intermediate and high-risk tumors, there's no clear trend or practice pattern change. So it's really change around what to do for low risk and very low risk tumors. So we are currently finishing up the American Thyroid Association guidelines for the management of differentiated thyroid cancer. As you've heard, I have had the great privilege of being able to co-chair that committee with Dr. Matt Ringel, an endocrinologist from the United States. I want to reassure everyone these guidelines reflect a transdisciplinary approach with both endocrine surgery and otolaryngology represented. For the first time, long overdue, we have nuclear medicine leaders. We have a genetics counselor, long overdue, and perhaps the voice most neglected over many, many years has been the patient voice, with Gary Bloom representing that. We've also integrated a methodologist into our guidelines writing group. These are the folks, and I wanted to focus on the surgeons and acknowledge and show gratitude to them, to endocrine surgeons, to otolaryngologists that have helped to assemble these guidelines. So just as later in this webinar, we're going to do a case or a couple of cases, I'd like to apply our recommendations around surgery by walking through a clinical scenario, starting with a 33-year-old woman. She notes a neck mass, she has no other symptoms, and she is biochemically and clinically euthyroid. She undergoes the thyroid ultrasound, which shows in the left lobe a 2.5 centimeter spongiform nodule, almost certainly a benign nodule. But in the right lobe, perhaps the more worrisome lesion, the culprit, a 1 centimeter nodule with calcifications, irregular borders, no posterior invasion, and hypervascularity. No pathologic lymph nodes are seen, and FNA is performed of that 1 centimeter sinister appearing nodule, and it reveals papillary thyroid cancer. So the question is, should you do a total thyroidectomy? Should you do less surgery? Should you do surgery at all? Well, if we go back, let's pivot and look backwards first. In 2015, if we think about the ATA guidelines, the answer would have been thyroid lobectomy alone is sufficient treatment for the overwhelming majority of small unifocal intrathyroidal carcinomas in the absence of certain other specific features when the nodule was less than 1 centimeter in size, a word that was two-letter word often neglected from those guidelines if surgery was chosen. And that was really where we opened the door just a tiny crack to allow consideration of active surveillance as an alternative to thyroid surgery. Well, there is going to be a frame shift later this year coming from the American Thyroid Association. And this is the draft recommendation 11, and you will see all of my slides are watermarked with draft. These are all draft recommendations. They have been vetted by the ATA membership, but they are only about to start to undergo peer review. But this is sort of the debut of these recommendations. And here we say, active surveillance may be offered as an appropriate management option for some patients with T1A PTCs, so papillary thyroid microcarcinomas. Shared clinical decision-making between the patient and clinical team regarding risks and benefits of this approach is essential. This is a conditional recommendation based on low certainty evidence. But now, as you see, active surveillance is coming up to really stand on a level playing field for some patients with these very low risk tumors. So you could say, well, Julianne, where the heck did that big change come from? So our guidelines writing group is not just writing guidelines. We are also doing science that will be serving as an underpinning to some of our guidelines. This meta-analysis systematic review was published in the journal Thyroid in 2022. And what we did is we started with 719 studies, but based on a number of inclusion and exclusion criteria, we finished with just 18 studies. And the purpose of this systematic review was to compare active surveillance to upfront thyroid surgery for very low risk differentiated thyroid cancers. So in the end, we wound up with just 18 studies. 8 were cohort studies, 1 cross-sectional study, 6 uncontrolled treatment series. Sadly, 5 studies were rated fair quality and all the others were rated poor quality. Not a criticism of our colleagues and scientists, but rather a call to do more and better science. So we focused on low risk, primarily papillary, small, less than or equal to 1 centimeter DTCs, again, comparing immediate surgery versus active surveillance. What we found across both groups was a low risk of all-cause or cancer-specific mortality, low rates of distant metastases, low rates of clinical recurrence. And when patients did undergo active surveillance, the rates of tumor growth were low, and the rates of subsequent surgery varied, but almost always were due to patient preferences, specifically patient anxiety and inability to comply with active surveillance as opposed to progression of their disease. Strong conclusions really were not possible because of the variation in study design, the overall low quality, and clearly more research is required. Well, you could say if we're going to recommend not surgery, but active surveillance, how are we going to do that? So our draft recommendation 12 says that for patients undergoing active surveillance, neck ultrasound should be used to monitor for progression. These ultrasounds should be done Q6 months for 1 to 2 years and then annually. Recommendation 13 for patients undergoing surveillance, routine measurement of serum thyroglobulin and or antithyroglobulin antibodies is not recommended. Both of these are relatively weak recommendations, conditional and a good practice statement supported by very low quality evidence. And finally, and no one has seen this draft recommendation yet, so LATS AES are the first draft recommendation 11B. Dr. Volpe will be happy with this. Ultrasound-guided percutaneous ablation may be considered as an alternative to active surveillance or resection for CT1A and 0M0 PTCs in select patients, a conditional recommendation with low certainty evidence. Well, what happens if a patient does progress? How do we define progression? And what if they become anxious? So this is draft recommendation 14. In patients undergoing active surveillance, surgical resection is indicated if there are new metastases, if the primary tumor grows by 3 or more millimeters, if there's the development of distant metastases, if there is evidence of extrathyroidal extension or posterior growth, and when there is patient anxiety or expressed preference for surgery. And I will say to you, as there is an increasing amount of evidential equipoise in the management of differentiated thyroid cancer, the patient voice and shared decision-making has taken on greater gravity. Well, in the case of our patient, she chose to undergo active surveillance, but there was nodule growth to 1.3 centimeters. The patient felt anxious and wanted surgery. So the question then is, if you decide how much you decide to do surgery, the question is, how much surgery should you do? And should you do total thyroidectomy? And in 2009, the correct answer was total thyroidectomy. In 2015, we evolved that to say that the initial surgical procedure could be either total thyroidectomy or thyroid lobectomy. Either answer would be appropriate. Well, in 2025, there will be an anticipated change in that recommendation. This is draft recommendation 15A. Total thyroidectomy is now falling away. And we're going to say when resection is performed for patients with cancers less than or equal to 2 centimeters, without extrathyroidal extension and without metastases, the initial surgical procedure should be a thyroid lobectomy unless there are bilateral cancers or other indications to remove the contralateral lobe. This is a strong recommendation based on moderate certainty evidence. Well, that number 2 centimeters is going to be a cut point. Continuing with recommendation 15B, not our patient, but for patients with tumors 2 to 4 centimeters in size, a nuanced edit on that prior recommendation. Thyroid lobectomy may be the preferred initial surgical treatment due to significantly lower risk and side effects. So an equivalent long-term outcome, but with clearly superior short-term outcomes. 1 to 2 centimeters should be lobectomy. 2 to 4 centimeters may be the preferred approach. Thyroid lobectomy and total thyroidectomy starts to fall away. Again, draft recommendations, what we anticipate. But are we legislating this? Are we forcing people to do something that we don't want to do? So no, we aren't. And we definitely think there is wiggle room based on shared decision-making. But I will say one thing that hasn't changed for total thyroidectomy is that that is the recommended approach for patients with tumors greater than 4 centimeters, cancers of any size with gross extrathyroidal extension, clinically apparent metastatic disease to lymph nodes or distant sites, total thyroidectomy with gross removal of all primary tumor and node dissection should be performed unless there are contraindications to this. So total thyroidectomy still has a place in our toolkit. It is just a modified place, and that is a strong recommendation with moderate certainty evidence. But the patient and the treatment team may, of course, adopt total thyroidectomy for smaller tumors if there are indications, like the ability to administer RAI, to enhance follow-up based on disease features, for suspicious contralateral nodularity, or if, frankly, the patient prefers that. When thyroid lobectomy is offered as initial treatment, completion thyroidectomy may be indicated at a later time, a conditional recommendation. So in this case, our patient said, there's a nodule in the contralateral lobe, even though it's probably benign, I want a total. So a total thyroidectomy was performed without complication. In the right lobe, there was a 1.6 centimeter papillary thyroid cancer with microscopic invasion, negative margins, 1 of 5 lymph nodes had a micrometastasis without extranodal extension. So this is a stage 1 tumor with excellent anticipated long-term survival. She would be in a low-risk category for residual disease or recurrence, and we would not recommend the administration of radioactive iodine. So I do want to anticipate a question. People may say, okay, you're moving away from total thyroidectomy and total thyroidectomy with radioactive iodine. What are we going to do with thyroglobulin levels? So this is another piece of science, a meta-analysis systematic review that our group published in 2022, asking about the most appropriate role of serum thyroglobulin levels as we evolve surgical management. We started with 827 studies, but finished with just 37. Why? Because there were so many serious problems with methodology and precision, inconsistency, and indirectness. What we could say is that following partial thyroidectomy, TG measurement was really fundamentally not that accurate for diagnosing recurrence or metastasis, and most estimates were imprecise. Following total thyroidectomy without radioactive iodine, TG levels were imprecise at best. They were usually stable and low. Why? Because, of course, patients had low-risk disease. What was the problem? The problem is there are no data. The data that exist are data for thyroglobulin, antithyroglobulin antibody measurement following total thyroidectomy with radioactive iodine. But we're doing more hemithyroidectomy and more total thyroidectomies without I-131. So the problem is these data don't exist. If we're going to use a threshold, it's probably less than 1 to 2.5 nanograms per milliliter. That probably defines a low likelihood of your having residual or recurrent disease. So to finish, what would I say in summary? Am I saying less is more? And I got to tell you, I love this slide. It's a catchy image. It definitely catches one's attention. But I think that is oversimplistic. And I don't think where we are evolving is to less is more. These words of wisdom were said by an American architect, not an endocrinologist or an endocrine surgeon or head and neck surgeon. This is Frank Lloyd Wright. And he said, less is more only when more is too much. And I think really where we are landing in 2025 is to take a personalized approach to each and every patient based on their demographic, pathologic, and clinical characteristics, and also based on the molecular underpinnings of their tumor. Importantly, throughout the process, it is so important to put the patient at the epicenter and to embark on shared decision-making, where the transdisciplinary team listens to the patients, their values and preferences before offering a recommendation about treatment. And I hope that after this webinar and going forward, all of us will not resent change. We will embrace change, at least change that is informed by evidence. Thanks so much for the opportunity to present.
Hi, Julianne. We thank you. It's an amazing, amazing talk. Thank you very much. Now, Dr. Vogt.
Okay, thank you, Dr. Sosa, for the presentation. And this is an honor to be here today. Thank you, Dr. Evandro, for work together in this meeting. It's an honor to present Dr. Heriberto Volpi. I think that all the present know him, but he's a head and neck surgeon of Sao Paulo, Brazil. He's very famous for the radiofrequency ablation. And today, his topic is my favorite topic, and I present this. We will talk about why choose RVA over active surveillance for macro papillary thyroid carcinoma. Thank you, Heriberto, and thank you both associations for inviting me in this night. Thank you.
Thank you, Anna. Thank you, everybody. Thank you. It's honestly, it's a great honor to be here to participate in this combined meeting of both societies that I have the honor to be part of, and for inviting me to talk about a topic that I really love, and it's an important part of my daily practice nowadays. I declare that I have no conflict of interest. As I told you, as a member of both societies, and I want to start my presentation with a very common case in our daily practice. A very young patient that made for the first time ultrasound and discover an incidental thyroid nodule. And when she came to the endocrinologist, the FNA was already performed. And it's, once again, it's very common in our practice. And the nodule was Bethesda 6. So now we have a lot of options. Sometimes we have some doubts. What's the best way to go? We know that the journey of the patient had some issues. Now we have many choices. We can choose active surveillance or surgery, but some patients suffer from anxiety to stay with a cancer in the neck, or have some complaints about scar. So what now? What can offer for some patients? We know that the standard approach for treat thyroid cancer is the total thyroidectomy plus iodine therapy, followed by hormone suppression. However, in the past years, in the 10 last years, there is a game changing towards more conservative management strategies, such as active surveillance or thyroid lobectomy for selected patients with low risk thyroid cancers. It's important we have in our background active surveillance, because it's a very good option for low risk papillary thyroid cancers. And HA suggests that could be the first line management, not treatment, for low risk papillary thyroid cancers. Active surveillance has promising results. However, especially in our practice, many patients desire surgery. And a recent review and meta-analysis shows that anxiety of the patients was the main reason for a representative proportion of the patients stop active surveillance and look for the treatment. And of course, surgery is the first line treatment options for patients with thyroid cancers. But we know that the occurrence of intraoperative complications can occur, especially recurrent laryngeal nerve damage and hypoparathyroidism. And even we perform a lobectomy, post-surgical hypothyroidism can occur. And we know active surveillance is very safe, is effective, of low risk. However, many patients are not interested in active surveillance and search for less aggressive options just to treat just the small cancer without having without having to go to thyroid surgery. The main reason of these patients search for less aggressive treatments is the concern about their quality of life. So in response to this need, percutaneous ablations has emerged as a good option between active surveillance and surgery. Now, these treatments are being used to destroy intrathyroid papillary thyroid cancers. It's important to understand, here we can see a small thyroid cancer, and it's important to understand that the technique of ablation for malignancies is a little bit different for benign nodules. When we reach the cancer, we treat an area bigger than the nodule itself. We treat the nodule and a surrounding normal area as a safe margin. These technologies use ultrasound to insert a needle that delivers thermal energy reaching up to 90 Celsius degrees, destroying, causing necrosis of the nodule. These procedures are made by just local anesthesia or light sedation. It's in an outpatient setting. And it's important to understand that now thermal ablations can be done effectively by different backgrounds, including endocrinologists, radiologists, surgeons, and interventional radiologists. And the key of the success when you choose thermal ablation for treat micropapillary thyroid cancers is the correct selection of the case, not just the nodule itself, but also the patient characteristics and the medical team. And now you have active surveillance, thermal ablation, and thyroid lobectomy for small cancers. So you should balance which is the best for the patient. And this is the most important slide in my presentation. This is a recent paper from Dr. Tuttle from Memorial. And you can divide the patient of the case with the characteristics of the nodule, the patient, and the medical team. And it's very important. We have the ideal patient that it's very, very, very committed to preserve the thyroid. He has a nodule in the perfect conditions, less than 1 centimeter inside the thyroid.
Heriberto,
Heriberto,
you are mute.
thank you. No audio. Heriberto, I think
Heriberto,
1
I
minute.
cannot hear.
I call him. Heriberto, we have problem with the audio. I don't know what happened.
Sorry, we have a technical problem. We are working to solve it. Thank you.
Can you hear me now?
Yes, it's
Okay.
okay.
Sorry.
No problem. maybe the last 2 or 3 slides, we have problem with the audio. At this point, it's okay. No. The audio is not okay with you put the PowerPoint. No. No. Evandro, do you have a good audio at this moment or not?
No, no, very,
No.
it's a very low, your audio is
Yes.
very low, Edivelto.
When you put the PowerPoint, we have the problem. We are without the PowerPoint, we are okay. Not, we haven't have it. Okay. No, it's very low. No, no, I don't have audio at this moment, Heriberto. Maybe if you change the PowerPoint to the computer, oh no, I don't know. We have a very good audio in the first moments of the talk, but I don't know what happened.
Eu não sei se você ainda vai falar com ele.
Evandro,
Dr. Volpe has disconnected and he's
yes,
trying to get back.
okay.
Cristiane, ele desconectou e vai entrar de volta, tá? Para tentar resolver o problema.
Did you saw this presentation, this slide that I told you this is the most important slide of my presentation because you can choose between, you can consider the characteristics of the nodule itself, the patients, and the medical team. And you can classify the patients in the ideal patient that has small nodules inside the nodule, inside the thyroid, and the patient with a strong committed to preserve the thyroid, and with a medical team that it's acquainted to thermal ablation therapy. But you have also the appropriate patient that is that has a nodule up to 1.5 centimeter, they have a patient that has a history of familiar thyroid cancer, but this patient is ineligible or refuse surgery. It's not the perfect patient, but if the team has experience, thermal ablation could be an option. And of course, we have the inappropriate patient. There is a tumor close to the trachea, close to recurrent nerve, more than 1.5 cubic centimeter. The patient has a small nodule, but he doesn't care about preserved thyroid. He wants to take out the disease and some medical teams that has no experience. So you should balance the nodule, the patient, and the medical team to choose the best treatment. And as I showed, when you treat small cancers by ablation, you treat not only the nodule itself, but a surrounding area. It's a safety margin. So at the beginning, the treated area is bigger than the nodule itself. So after some months, the area will start to shrink, and you can expect a reduction of about 50% at 1 year. But after 2 years, almost 100% of the nodules will disappear. This is an example of a patient that we treated by RFA. It's a nodule on the transition between isthmus and right lobe. You can see here the nodule before RFA, 2 months after RFA, and you can see the treated area much bigger with a very good safety margin. 6 months started to shrink this area, and after 1 year, the tumor totally disappear. You can see an area of the retraction where was the tumor. When you compare, and it's hard to compare active surveillance, that is a management, with ablation. There is no ways to compare. But when you compare ablation with surgery, you can see the results of well-selected patients. It's the most important, the correct selection of the patient. The results are almost the same, and the complications are much less than surgery. So when you carefully select the patient, the ablation has the same oncologic outcomes after 5 years when compared to surgery. The complications and costs are lower, and the quality of life is better. Of course, we need longer follow-up to demonstrate if these findings are durable and reproducible. Some meta-analysis of the treatment of microcarcinoma by thermal ablation showed a disappearance of almost 60% after 5 years. And one important point when we choose to treat those patients by thermal ablations is that you can reach a reduction of 80% of the patients with the total disappearance, but not all nodules will completely disappear. But it not means that the tumor is still there, because in some patients there are a scar or a minimal nodule that not represents the presence of the disease. For instance, another patient that underwent ablation, and after 1 year, there is a very, very small area of a residual area that was, this patient underwent 2 5-needle ablations with no cells. And after 1 year, after 2 years of ablation, you can see the complete disappearance of the tumor. So it's important to understand that sometimes the presence of a small area not really represents the residual disease, but it's very important to follow these patients in a close manner. Of course, as any other procedure, you can have complications in ablations, and the most important complication is voice change. Voice change, it's the most important as in surgery. And this meta-analysis showed that a level of voice change of 1.5%, and minor complications, pain, alterations of hormone levels, uh, uh, hoarseness with a short period, and hematomas can occur also. But when you compare the quality of life of those patients with surgery, you can see that ablation offer a very good quality of life, much better than surgery in most patients. So to finish my presentation, sorry for the mess. That patient at the beginning of my presentation, he showed ablation, and you can see after 3 months, the treated area bigger than the tumor. And the reduction, according the time goes by, and after 1 year, the complete reduction, complete disappearance of the tumor remains just a scar in the area where the tumor is. So thermal ablations represent a new option for treatment, but you can balance all the options and show to the patient all the options he has. This procedure is feasible, effective, and safe. We should master this technique because this technique, thermal ablation, should be part of our therapeutic arsenal. It's an alternative to surgery in selected patients and selected nodules. And of course, more research is needed to improve these results. Once again, thank you, and sorry for the mess. Thank you.
Thank you,
Heriberto, for the lecture. Is very, very good lecture, and I agree with your comments, and I add that is for select center too, maybe this indication. Well, it's an honor to present the moderators of this webinar. Maybe we will have a very good discussion because we have endocrinologists and surgeons, and this is very good for this topic. I will present Dr. Jennifer Gu, that she is Associate Professor of Endocrine Surgery in Columbia University. Thank you, Jennifer, to be today with us. Dr. Fabian Pitoia, he is head of thyroid section, and he's endocrinologist too. He works in Hospital de Clínicas of Buenos Aires, Argentina, and he was former of LATS president. Thank you, Fabian, to
Hello, everybody.
here. And Dr. Kowalski, I think all know him, but I will present you. He's professor of head and neck surgery of the University of São Paulo, Brazil, and he is head of reference center of head and neck tumors at Camargo Center, Cancer Center. And he's the coordinator of the Surgical Affairs Committee of LATS. Thank you to be here. And Evandro, you have 2 cases to present at this moment and to discuss with us. Thank you.
Thank you, Juana. Thank you for the kind introduction, and thank you for the panelists. So it's time to discuss the cases that you want to propose to our panel. So the first case came to the visit in March 2024. So it's a woman, 55 years old. She's a business person, and she had an incidental diagnosis in 2021 of a thyroid nodule. She underwent FNA in August 2023, and the
Excuse me,
diagnosis.
Evandro, you can open the presentation.
Oh, yes. Sorry.
Thank you.
Sorry. Thank you. She underwent an FNA in August 23 that diagnosed a Bethesda 3 nodule in this left lobe on her medical routine checkup. She complained no symptoms. She had no family history of thyroid cancer, and she had no history of radiation exposure. She had no chronic diseases, and she says that she hates medicines. She would rather take herbal tea than any kind of medicine. So she just told me at the beginning that she does not want to take any thyroid hormone. So the ultrasound from August 23, it was there was a on the left lobe 5 by 4 by 7 millimeters that underwent FNA of Bethesda 4. In the left lobe too, a 7 by 5 by 6 millimeter nodule with the FNA Bethesda 6. The right lobe had a 6 millimeter nodule, unsuspicious, with no FNA, and a 20 millimeter nodule with no FNA too, and unsuspicious nodule. She had a lymph node on the neck that underwent an FNA that was negative for malignancy. So when she came to the visit, she was complaining of a lot of emotional distress because of the Bethesda 6 diagnosis. She had normal lab tests, and at that time in March of 24, as her last ultrasound had more than 6 months, we performed again another ultrasound with no change on the nodules. It was pretty stable. There was actually a 1 millimeter difference below in the biggest node in the right lobe, and the cervical lymph node was reported to have an inflammatory aspect. So this is the 20 millimeters right nodule, right lobe nodule. This is the other one that is a 6 millimeter nodule in the right lobe. On the left lobe, this is a ThyRADS 3 lobe that was biopsied with a Bethesda 4 diagnosis. And the other one in the left lobe, that is a Bethesda 6. This is the nodule that caused all this consultation. So, and this is the lymph node that was already biopsied and it was negative. So I'm going to open this question to the panel. Are you colleagues missing any test or anything to improve the workup of this patient? Dr. Kowalski.
No, I think that, sorry, I think that we have sufficient information to inform the patient and take the decision. Maybe we could discuss molecular tests, but it wouldn't change my mind on the recommendation.
Thank you, Dr. Kowalski. So,
Can I
yes,
say something,
sure.
Evandro? Because probably a patient with a multinodular goiter like her, I would like to have a calcitonin level. That will help me a lot to move more comfortably and reassuring her that those that were not finally aspirated, or also even the category 4 thyroid nodule, probably is not a medullary thyroid cancer. So we usually have calcitonin measurements in these patients.
It's a great suggestion, and she had a normal calcitonin on that routine medical checkup that when she got the diagnosis. So it's normal calcitonin. So we talked about the options we had, and we talked about active surveillance, we talked about ablation, and we talked about surgery. And she asked some time to think at that time. So I said, maybe we are safe to proceed. So taking your lead, Dr. Pitoya, would you consider at this very first time to recommend active surveillance to the patient?
Well, I used to classify, this is my own classification, of course, of these kind of patients. Like I try to put them in a way where I can understand the way they think. Probably this patient having the thyroid nodule diagnosed in 2021, and then being having the final aspiration biopsy in 2023. We, with Dr. Smulever in Argentina, we have published this, and we call these retrospective active surveillance. We have like 2 years of follow-up of the thyroid nodules that seem to be very similar. Now we have the final aspiration biopsy. I would rather ask why subcentimetric thyroid nodule was finally aspirated. So that's the first question. And then I try to classify this patient into maximalist. Obviously, she's not a maximalist patient. And then minimalist, probably she's not a complete minimalist patient. But the phrase you said at the beginning that she preferred herbal tea more than a medicine makes me think about that she is more prone to be minimalist than a maximalist patient. And so in the middle, there are two other patients, probably what I call the moderate interventionist. That could be the patient that doesn't feel comfortable going with active surveillance, but probably would choose something more near to the surgery, probably the patient who chooses lobectomy, and then those patients who choose the conservative interventionist patients, and these are the patient who want to do something, but they don't want a surgery, and probably radiofrequency ablation is something that they choose. So in this patient, I will try to explain her this long-term follow-up, at least 3 years or 4 years of follow-up of these thyroid nodules. And this is a very ideal nodule, at least the Bethesda 6, a very ideal nodule for active surveillance. If you look at the ultrasound, you can see clearly that it has normal thyroid tissue all around the thyroid nodule. And of course, this takes a long time to explain the patients that they will have the same outcome probably if they choose total thyroidectomy, lobectomy, radiofrequency ablation, or active surveillance. So I will take the job to convince this patient to wait. She already is on active surveillance because she has more than 1 year on active surveillance.
Great. So she asked me at that time some time to think about her options. And she came back 6 months later in September of 2024. And she said she was really afraid if that lymph node was really negative, because she read that papillary thyroid carcinomas can metastasize to lymph nodes. So she wanted to be sure that she did not have a metastasis on the lymph nodes. And I said, we can do it again. So we can be comfortable on deciding whether is the best option for you. So she underwent another neck ultrasound. We did not any FNA on the nodules that we already FNA'd, but we repeated the FNA on the lymph node at the left side, and was again benign cytology with the negative thyroglobulin on the needle washout. So we could reassure that there is no metastasis on the neck. And this is the situation we had. So this is the evolution, actually no evolution of the nodule. So on the left lobe, we have a Bethesda 4 and a Bethesda 6 FNA diagnosis on sub-centimeter nodules. And on the right lobe, we have a 2-centimeter nodule that is Bethesda 2, and another one that is a sub-centimeter one with no FNA. Dr. Cool, how would you manage this patient? How would be your approach?
So, you know, I think she is still a candidate for continued active surveillance. I agree with Dr. Pretoya that she has a 18-month history of active surveillance at this time. Over this period of time, none of her nodules have grown significantly, and now we've reassured her that with the thyroglobulin, that lymph node is not representative of metastatic disease. So continued active surveillance is an option for her. Lobectomy, a left lobectomy to address that small subcentimeter nodule if she wants, is also an option. And thermal ablation is an option as well. But I would disagree with Dr. Pretoya that nodule is a perfect nodule, because to me, it looks like if you pull back up the images, that medial border is right along the trachea and TE groove. And so the image on the right side of the screen. And so that's depending on the cranial caudal location of that tumor, you may be looking at a tumor that's right adjacent to the insertion point of the recurrent laryngeal nerve. So from an active surveillance standpoint, this relatively young woman, if this tumor progresses, it could progress in the wrong direction involving that nerve. And certainly from an ablation standpoint, getting a margin, as Aravilto mentioned, on that medial border would be very tricky for someone who is not, who does not have expertise in hydrodissection.
Okay, so Dr. Kowalski, do you think this is a good candidate for surgery? I'd like to remember the panel that this is a very distressed patient, and she says that, you know, she would probably have surgery on the left side where there is a cancer, and she would like to preserve some of her thyroid. But she asked me also about the ablation. So is there a possibility to treat one nodule and leave the others alone? Well, how would you manage that, Dr. Kowalski?
Well, I think that we have to assure this patient that there is no rush to decide the treatment. Yeah, all the three options are good options, and I would take my recommendations based on the history, based on the data that you have presented. She seems to be very anxious, although she's waiting because maybe she's afraid of surgery. But if you put this patient in active surveillance, she will ask surgery in 6 months or in 1 year, as Dr. Sosa mentioned. I think that the experience of Fabian in Argentina also, a lot of patients cannot be maintained in active surveillance because they are not comfortable with this. This is a 55 years old woman, so the life expectancy is very of at least 20-25 years. So it will be, I think that it will be a problem to maintain active surveillance, but it's an option. If she decides to take this, I would follow this patient, and if she changes the opinion, I would operate. But My recommendation for her would be surgery as the first option. And I am not comfortable in doing partial thyroidectomy when we have a node of 2 centimeters in the contralateral side. Although it's Bethesda 2, I would recommend total thyroidectomy. It's a safe procedure. It will solve a lot of future problems because maybe this patient needs a totalization in the future. And I think that all the time when I have big nodes or multiple nodes in the contralateral side, my recommendation is for total. I think that it saves a lot of problems.
Thank you, Dr. Volsky. Julianne? Julianne, are you with
Hi.
us?
Yes.
Hi, Julianne. As this is the subject of your talk, and is this patient deserves a total thyroidectomy in your opinion?
Yeah, so no, no. So I think this is an interesting question. I also am very respectful of taking the culture and microclimate and microenvironment that I live and work in and assert that, the process of shared decision making is the same in San Francisco as in Buenos Aires, for example. So I do also want to reflect that, we have access in San Francisco to extensive molecular testing. I think we over test patients. We know all kinds of things that most people do not know and probably don't need to know. So that's the caveat. But I would not do a total thyroidectomy in this patient.
And
I would
think-
listen to what they say. The other thing, though, is I would make a recommendation to the patient, but then I would listen to the patient, and the decision we make would reflect their preferences.
Thinking on her distress. Yeah.
Can I make a
Sure.
question to Julie? Because I would like to, because we know that we have a suspicious thyroid nodule in the left lobe, then a Bethesda 6, and then we do not know if there is a multifocality of this tumor with this non-biopsied thyroid nodule in the right lobe. So if you recommend lobectomy for this patient, would you first do a fine needle aspiration biopsy of this right lobe thyroid nodule?
Which one? The Bethesda 2?
The one which is not biopsied.
No, it's sub-centimeter. So my observation is that we would continue to follow it. And, the data, I see Professor Miyauchi is on. We, have enough time to rescue this patient if that nodule were to grow, say, to 1 centimeter, 1.5 centimeters, was worrisome in appearance, we could biopsy and do the completion later. So,
I
no,
understand
would
that,
not
but I
biopsy.
think
You've got
I
it.
understand that, but I think that this is not following the same approach. If we biopsied 2 thyroid nodules smaller than 1 centimeters in the left lobe, and then we want to plan a surgery, probably we should follow the same idea of doing fine needle aspiration of that thyroid nodule and deciding to move if we are going to be maximalist or move into a surgery. So probably this is my question, because it is the only one which is not biopsied, and it's with the probably with the same characteristics of the left one, which is a Bethesda 4. So that's my question, because I agree that probably with Luis, that probably for this patient, total thyroidectomy will solve all the nodularity in the patient, and we can end up with all the thyroid nodules in good hands. But again, I think that in my opinion, I would suggest, although there is no indication for fine needle aspiration of subcentimetric thyroid nodules, in this case where we followed up another a kind of instructions to the patient, probably to do the same with the right lobe, in order to reassure her that this is a non-multifocal carcinoma.
Dr. Kuo,
Yeah.
if you would choose to treat this patient, and if she agrees with radio ablation, which nodules would you pick to treat?
So if again, I didn't explicitly say earlier, but I would favor surgery just because of that location at that medial border of the PTNCs. But if after full counseling and awareness that, even if the complete tumor disappears sonographically, that we would never be able to guarantee that every single cancer cell has been treated without taking it out. If she agreed, then I would offer to treat both of those left nodules, actually. And I would, but I would approach it, as Arivelto mentioned, I would approach both nodules as cancer, and I would overablate and ensure good margins on both of those nodules. The B4 nodule is actually much more, the location is much better for ablation. So that's, if that is the option that she went for, that's what I would offer her. To go back to the previous discussion, though, I think to Julianne's point, talking with the patient would really help. I think the question of whether or not to biopsy that nodule on the right side that hasn't been biopsied before, if the result were to change what you do, if the patient decided, if it's cancer, I want my whole thyroid gland out, then go ahead and biopsy. But if the result comes back as cancer and she still opts for active surveillance of the right side because she doesn't want to be 100% dependent on thyroid hormone medication for the rest of her life, then that would not change our operative plan, and we therefore, I think FNA would not be indicated.
Okay, Dr. Volpi?
Hey,
Erivelto?
hey.
Hey. So, how would you manage this patient, Dr. Volpi?
Well, honestly, my first option is surgery for this patient. I strongly recommend surgery for these patients. However, it's the perfect case where you can choose by the ideal, appropriate, and inappropriate patient, nodule, and team. Is it possible to treat by radio frequency? Yes, it's possible, but in a perfect world, 2 sessions at least. As Jane mentioned, treat before the left lobe to destroy both small nodules. And I will treat this Bethesda 4 as a malignant. So I will do not only the tumor, the nodule, but also a safe area. And in the second time, if the patient really deserves a minimalistic approach, and the second time, ablation of the right lobe. But once again, surgery is the best for this patient, in my opinion.
Okay.
So what are the votes at this point? So I voted for lobectomy, possible total. Fabian, were you voting for total?
No, I voted for lobectomy, but probably I
Okay,
would
so
ask
we're
for
agreement.
the
Oh, but you would
yes, with the
biopsy.
final aspiration of the other
Okay.
right lobe thyroid nodule, in just to ask the patient if I agree with Jennifer. This is very important to talk to the patient. If she doesn't care about the diagnosis and she prefers not to take medication, we cannot reassure that this will be the case. Probably I wouldn't do the final aspiration biopsy, but then I have my doubt is if this is the same or not.
So Dr. Kowalski voted for total.
Total.
So we have a victory of surgery in this discussion. Surgery wins. So I'll tell you that this case is not closed yet. The patient is still thinking about it, and she's prone to have a surgical resection of the left lobe and she asked me just to observe the right lobe, which management I tend to agree. So there is a benign nodule in the right lobe that is not doing any harm, and she tells that she's not going to be anxious, and she's comfortable of doing that. So she took some time to think about it again, because my proposal to her would be a total thyroidectomy, as Dr. Kowalski has proposed, but she came with this proposal back. So you take my left lobe and leave the right lobe. So I would take my chances of not having medication for the rest of my life. So we
She
are
came
still.
to San Francisco for an opinion. That's how that happened.
I'll tell her. I'll tell her that. So take some time there. Okay. I'll stop sharing here. Unfortunately, we are actually, I don't know how to stop sharing this. Sorry. Hello?
I think you've stopped sharing. I
You're
don't see.
ready.
Yes, yes,
Yeah.
Dr. Shin.
Did I? Okay. I'd like to thank you very much to our speakers and panelists. In the interest of time, unfortunately, we will not have time to discuss another case. I hope we have again this opportunity to go ahead and do some more cases and have this distinguished speakers and distinguished audience. So it's been a privilege, and I like once again to congratulate and thank the initiative of the AAES and LATS of giving us this opportunity to bring some amazing talks and this very rich discussion. I'd like to thank the audience, the speakers, and the panel for joining us tonight, and hope to see you very, very soon. Thank you very much, and hope to hear from you. See you guys for the next webinar. Okay,
Bye.
Thank you.
Thank you so much.
thank you very much. Have a good night, guys. Thank you. Thank you.